All right. Well, welcome everyone. I'd like to give you a warm welcome to Ethics Grand Rounds. I am Sandra Sujin Lee, Professor of Medical Humanities and Ethics and Chief of the Division of Ethics here at Columbia University. I am absolutely delighted that you are joining us for our first Ethics Grand Rounds of the academic year. This is on normothermic regional perfusion and the ethical challenges in the transition from life to organ donation. Ethics Grand Rounds is a series organized by the Division of Ethics in the Department of Medical Humanities and Ethics. The goal of Ethics Grand Rounds is to engage our community of health professionals, scholars, scientists, and trainees across career stages and disciplines by centering important topics and debates in medical ethics that relate to clinical practice, research, implementation, and education. Our hope is that attendees will leave each session with a greater understanding of the ethical and social implications of the topics that are being discussed. This series is co-led by Lucas Matthews, Assistant Professor in our Division of Ethics, and is the result of efforts of our organizing committee made up of faculty affiliated ethics division faculty, research and program staff. And I want to thank these individuals for their dedication to our monthly series. There are several additional series sponsored and organized by the Division of Ethics. I want to make sure that you know about two upcoming events that are going to take place in the next few weeks. These are Talk RX and Bioethics in Film. And in terms of Talk RX, this year, this will be held on Thursday, October 24th at 6 p.m. Here in VEC in room 201. There will be a reception preceding the event at 5 p.m. in the lobby. Talk RX is an evening dedicated to live storytelling where real experiences and narratives from the medical field are shared in an intimate and supportive setting. This series is founded and led by Pablo Romano, a second-year psychiatry resident, and includes speakers from across the medical profession who tell their stories about everything from coming out to conservative parents to the Me Too movement and medical training, living with traumatic brain injury and mental illness, overcoming homelessness, dating in medical school, and much more. The second event that I want to make sure that you have on your calendars is our Bioethics in Film Screen to Seminar series, which will kick off this year on Thursday, November 7th. Again in VEC, actually in this room at 6:30 p.m. The film that we'll be featuring is Happening, which was directed by Audrey Dewan. It focuses on an exploration of reproductive rights and a range of other bioethical issues. Our speaker will be Carol Sanger, Barbara Ehrenstein, Black Professor Emerita of Law from our law school here at Columbia. She will be in conversation with our bioethics and film faculty lead, Alexis Walker, who's an assistant professor in our Columbia Division of Ethics. Prior to the discussion, there will be a special screening of the film happening in VEC 902 at 4 p.m. preceding the discussion seminar. So if you are interested in seeing that film in a group setting here at VEC, please do join us at 4 p.m. and the discussion will follow up thereafter. And there will be refreshments. All right. Okay, so now for the focus on our topic today for Ethics Grand Rounds. We are exploring, as I mentioned, normothermic regional perfusion, or NRP, which is a technique used following the declaration of an organ donor's death and aimed at improving organ quality by reducing cold ischemic time through recirculating oxygenated blood in the donor body before organ recovery and transplantation. Whether and how to administer NRP are contested questions that are answered by and large locally, including healthcare systems and institutions like our own, which has resulted in a patchwork of practices and policies. Several ethical questions are raised by the technique, that center on its potential utility, given the shortage of organs needed by patients, potential harm to the donor patient, and how the principle of respect can be achieved for families, along with goals of transparency to ensure that we maintain public trust. Addressing these concerns require a nuanced understanding of how NRP may be administered, including the sequence of events and actions, the nature of intentions, and current definitions of death. We are delighted to have none other than Dr. Ken Prager, who co-chairs the Adult Medical Ethics Committee here at Columbia, to present our approach for our institution. But before I introduce him, I'd like to go over some housekeeping details. We have quite a number of folks joining us by Zoom, and just wanted to alert those joining by Zoom to please use the Q&A box to register your questions. We hope to have a robust discussion after Dr. Prager's presentation. I also want to know that the session today is being recorded, and the recording will be uploaded as a resource on the Columbia Division of Ethics website following the event, along with readings that we think are helpful in terms of understanding this particular topic. Now, it is my great pleasure to introduce our speaker. Dr. Ken Prager is Professor of Clinical Medicine and Director of Clinical Ethics and Chairman of the Medical Ethics Committee at Columbia University Medical Center. He spent 2 years in the Indian Health Service practicing general medicine on the Cheyenne River Sioux Indian Reservation in South Dakota after his medical internship. Dr. Prager held clandestine medical clinics in the Soviet Union during a visit to Perfusion in 1986, and later set up the first US-Soviet medical student exchange program between Columbia PNS and the first Moscow Medical Academy. Dr. Prager has been a pulmonologist for over 35 years. He is heavily involved in teaching pulmonology and medical ethics to medical students, house officers, and nurses. His writings on medicine and medical ethics have appeared in medical journals and textbooks, as well as on the op-ed pages of the New York Times and the Wall Street Journal. Dr. Prager is a regular guest lecturer for the Ben Gurion University MD program in international health and medicine in collaboration with Columbia University Health Sciences. He has received many honors for his teaching, clinical expertise, and contributions to organ donation and medical humanism. It's an absolute delight to welcome Dr. Prager.
Oh, that's the next one. Thank you very much, Dr. Lee. And there's one correction I would like to make in my introduction, and that is that I have been practicing pulmonology for a half century, not 35 years. So, and I like to say a half century. It carries more weight than 50 years. Anyway, it's a delight to be here. And this entire subject is complicated, folks. And so in the half hour that I've been allotted, I hope to be able to get across to you some of the nuances, ethical nuances, medical nuances that are involved in this particular subject. So in terms of organ donation, probably there is nothing more dramatic in the field of medicine than the restoration of health to people who are dying with organ failure. And so organ donation is an incredible achievement of medicine. And in my own field of pulmonology, when people are given lung transplants, you see people going from, with oxygen, walking from here to there, being breathless, near death, to having no oxygen, being able to jog, and so forth. So and the same goes, of course, for heart donation. There are, however, I should say, potential ethical conflicts. And they are, there is on the one hand, there's the ethical imperative, obviously, to save as many lives as possible with organ transplantation. However, the supply of organs does not meet demand, and patients continue to die on the waiting list for organs, whether it be heart, lungs, kidneys, pancreas, etc. But how to get viable human organs from human beings involves significant ethical issues. These organs are not obtained, I should be over here.
Making
Okay.
more sense.
Okay, sorry, I should be standing here. These organs are not gotten from Macy's or from Costco. They're taken from human beings, and the manner in which they are taken involves some significant ethical questions. Now, the dead donor rule is something that underlies all of organ transplantation in terms of its ethics. And what is that? It's intuitive. The retrieval of vital organs should not cause the death of the patient. We should not kill living people for their organs, even to save somebody else's life. Therefore, the patient must be dead before the retrieval of organs. When are you dead? Now, up until organ transplantation, the exact moment of death was not critically important. So when Abraham Lincoln was assassinated, it was not critically important to know whether he died at 10 a.m. in the morning, 10:35, et cetera, et cetera. There were no practical implications or ramifications of that. However, when we take an organ from somebody, an organ that is sustaining life, we have to know the precise second in which we declare death. The longer we wait in obtaining an organ, the less useful that organ becomes. We don't want to take the organ too soon, lest we kill the patient and violate the dead donor rule. We don't want to wait unnecessarily too long, lest we destroy the usefulness of the organ. So, so how is it possible to do a heart transplant, to take a heart from somebody to save another life without killing the patient? If we wait for the heart to stop completely, and we wait too long, the heart will not be useful. So in 1968, a new definition of how you could die was enunciated by an ad hoc committee at the Harvard Medical School. Up until that time, the circulatory definition of death was basically how people were pronounced dead from time immemorial. Namely, once there was irreversible cessation of circulation and breathing, the patient was considered dead. The Uniform Determination of Death Act in 1980, which enunciated two ways in which you could die, we have subsequently modified the term irreversible cessation from irreversible to permanent. In other words, and you will see that in the process of donation after circulatory death, we declare a person dead even when it is possible to reverse their circulatory arrest, but we do not intend to do so, and therefore the circulatory arrest is permanent because we will not resuscitate them. The other definition of death is the brain death definition, which was enunciated, as I say, in 1968, and that is the irreversible cessation of all functions of the entire brain, including the brain stem. In other words, you could have a patient whose heart is beating, kidneys are functioning, GI tract is functioning, hair is growing. The patient is alive in all respects, except for the fact that there is no blood flow to the brain. The brain has ceased to function. And so the Harvard ad hoc committee said, such a person is dead. And therefore, if that patient is on a respirator, which is breathing for them mechanically, and their heart continues to beat, you may take their heart out and you are not killing them, because they are dead not by circulatory criteria, but by the new brain death criteria. Now, a word then about DCD, or organ donation after circulatory or cardiac death, because that segues into the normothermic regional perfusion. What is the clinical circumstance under which this occurs? Generally speaking, there is a patient who is critically ill, usually a patient with devastating brain damage, either from a hemorrhage or a gunshot wound or a brain tumor. And the family says, given the fact that my loved one will no longer be able to regain consciousness, will remain vegetative for the rest of their life on a respirator, we want you to remove the ventilator and allow them to die peacefully, because this is not a quality of life that they would want. And so in that case, the patient's family may be approached and said, would you permit, or would your loved one have wanted to be an organ donor? And if the answer is yes, the patient still alive on a ventilator is taken to the operating room, is prepped and draped as for surgery to retrieve the organs, and life support is withdrawn. Generally speaking, it is taking the tube out of the patient's lungs, and the patient has been already, it is clear that the patient will not be able to sustain respirations on their own. We take the ventilator off. If we don't kill the patient, we do not give the patient a lethal dose of medication. We allow the patient to die of their underlying disease. If the patient's heart stops within 1 to 2 hours, we wait for 5 minutes after the cessation of heartbeat, and then we pronounce the patient dead by the circulatory criterion, namely the permanent cessation of circulation. We do not intend to resuscitate the patient. The patient's heart has stopped after 5 minutes, and generally speaking, the likelihood of autoresuscitation is virtually nil. At that point, the patient is pronounced dead by circulatory criteria. The surgeons come in the room, they open up the patient and take out the organs that they feel are viable and will be used for transplantation. That is DCD, donation after circulatory death. Now, hearts retrieved in this manner are generally not usable for transplantation. Kidneys, yes. Livers, yes, although to a lesser extent. Lungs, yes, not hearts. There is a critical shortage of hearts to this day for organ transplantation. And so people came up with the idea, how can we get hearts that are viable using the DCD protocol? So people came up with the following idea. Let's replicate the DCD process. Same procedure, take the patient, the family says, generally speaking, and very often we see a lot of people who die now from fentanyl overdoses. There are a lot of people who sustain severe and irreversible brain damage, but are not brain dead. And the family wants to remove life support because they don't want them to stay vegetative the rest of their life, and they would like them to be an organ donor. Patient is taken into the operating room, the same procedure, prepped and draped. The patient is taken off the ventilator, and we wait. By the way, sometimes the patient does not have a cardiac arrest within 1 to 2 hours, and the patient is then returned to the ICU. They generally die soon thereafter. But again, we do not kill the patient. That would be a violation of the dead donor rule. So coming back to DCD with NRP, the patient, the ventilator is removed, just as in regular DCD. We wait. If the patient has a cardiac arrest within 1 to 2 hours, we wait 5 minutes and we say the patient is dead by circulatory criteria. However, what we do that is different from DCD, we put a tube into the patient's lung through the mouth, into the trachea. We start to ventilate the patient. Then the surgeons do a sternotomy. They open the breastbone. This exposes the heart and the lungs, and cannulas are placed in a large vein to collect venous blood, unoxygenated blood, and a cannula is placed into the aorta, which is where the oxygenated blood goes to. And these tubes are connected to a machine called an ECMO machine, extracorporeal membrane oxygenator, which is basically a heart-lung machine. And the intention is to turn the machine on and to restore circulation. However, we do not want to resuscitate the patient's brain, which is not necessarily brain dead after 5 minutes. And so the surgeons, before turning on the machine, they tie off the blood vessels that go to the brain to prevent the brain from becoming resuscitated in any manner whatsoever. And once those arteries to the brain are tied off, then the ECMO machine is turned on and circulation is restored to the rest of the body, the heart, the lungs, the kidney, the pancreas, et cetera, et cetera. Here is a diagram of what is involved. So you see the blue line is the tube, the cannula that is inserted into the superior vena cava, which takes the unoxygenated blood. That line then goes to number 2, which is a pump, which replaces the action of the heart. The pump pumps the blood to 1, which is the oxygenator, which acts as an artificial lung, puts oxygen into the blood, and the blood that emerges from the oxygenator is red. It's oxygenated, and that tube, the cannula, then goes into the aorta. And notice that there are clamps, those sort of greenish scissor-looking things. Those are clamps for the blood vessels that go to the brain so that the oxygenated blood perfuses all of the body below the neck. So basically you have, and once that ECMO machine is turned on, invariably the heart starts to beat of its own. It has been resuscitated, and you can turn off the ECMO machine. And so here you have a patient, a preparation, if you will, or a patient who has no circulation to the brain. The face is blue because it's getting no oxygenated blood, and all of the rest of the body is pink, and the heart is pumping normally. And then the heart can be assessed for its suitability for transplantation. And if it's felt to be suitable, the heart is then taken out of the body. And it is felt that we haven't killed the patient because the patient was originally pronounced dead by circulatory criteria. We can take the liver if it's good, the kidneys, etc. But obviously this raises certain questions. Now, going back to the year 2000, when DCD, not NRP, when DCD was enunciated, the Institute of Medicine said that the reason that DCD is ethical is that the reason the circulatory definition of death is met in the DCD protocol is that after the 5 minutes of waiting, after the heart has stopped, there is permanent cessation of circulation because there is no intention to resuscitate the patient. So that heart will never be rebeating again. We don't resuscitate. And it said death occurs when cardiopulmonary function will not resume spontaneously and will not be restarted artificially. The DCD-NRP protocol is felt to violate, by many people, feels that this Institute of Medicine statement is violated, the stipulation, because in fact the patient is resuscitated with ECMO after the hands-off period occurs. We are in fact resuscitating the patient. The heart is beating once again. Now, that's really the heart of the ethical issue here. Is in fact the patient resuscitated in DCD-NRP? Does resuscitation occur, thereby retroactively invalidating the declaration of death by circulatory criteria? We said the patient was dead after 5 minutes, but then we resuscitate the patient and say, no, you're wrong. We're invalidating that declaration of death was not valid because it was dependent upon the permanent cessation of circulation, and you have restored circulation. In that case, when we take the heart out, we're actually killing the patient because we induce brain death. So the patient's no longer dead by circulatory criteria. Now the patient is dead by brain death criteria, but who made the patient brain dead? We did, by clamping off the vessels that go to the brain. So one school of thought says we are killing the patient by inducing brain death. Another school of thought says, no, we're really not violating the dead donor rule. What we're really doing, this is not resuscitation. This is just perfusing the organs in situ, inside the body, and therefore they remain dead by circulatory criteria, and the ligation of brain vessels doesn't really induce brain death. The patient was headed towards brain death anyway. There may have been a couple of brain cells still viable and so forth, and the patient's progress towards death was really not interrupted. The patient was going to die anyway, and so this ligation of vessels was just to make sure that there might not be any sensation and so forth, but really brain death was in progress anyway. Of course, the question is, if the patient's really dead, why do you bother to ligate the vessels? You don't ligate the vessels of a dead person, and you can see how this can go in either direction. Now, recognizing this key ethical principle, are we resuscitating the patient or not with ECMO? In 2020, Parent et al. From NYU, which was doing DCD NRP, they wrote an article in which they said that perfusing organs after declaration of death doesn't undermine the permanence requirement. Declaring death by circulatory criteria requires that circulation will not restart on its own. Okay. And here's the key. The medical team must not intend to restart circulation for purposes of the patient's medical benefit. That's my bold. They're saying, yeah, you are restarting circulation. You are, but since it's not for the patient's medical benefit, it's really not resuscitation. Now, that's a caveat that they arbitrarily made up, I think, to make themselves feel better. But nevertheless, that is the underlying ethical justification for this. And so therefore, in circulatory DCD, the donor is not resuscitated, the organs are perfused to prepare for donation. That's the critical point. Now, Parent goes on, and what about the ligation of the cerebral vessels? They state, once the patient's declared dead in accordance with accepted medical standards, and natural neuronal hypoxemia, loss of oxygen in the brain, and ischemia progresses to complete irreversible loss of brain function unimpeded, it is then impossible to restore circulation in a way that restores life. That's what they say. That, however, if that's the case, why bother to ligate the vessels then? If that's the way you feel, why are you ligating the vessels? The reason that neuronal hypoxemia and ischemia progress to complete loss of brain function is because doctors have ligated the vessels perfusing the brain. They have ensured complete loss of brain function by their actions. Now, there was an editorial in the American Journal of Transplantation by a lawyer and by a physician. And they raise a question legally whether the doctors who do this are committing murder. And this is a quote from their article, which is relatively recent, 2022. Although the intention remember that Parents said that our intention, we're not doing this for the benefit of the patient, therefore it's not really resuscitation. So the article says, although your intention may be important when evaluating the ethical acceptability of physicians' actions, the legal standard for determining death is bare of intent. A patient is dead when circulation neither can nor will resume. Whatever the intention, the fact, whether you intend to do it for the patient's benefit or not, the fact remains that NRP restores circulation and indeed can restore heartbeat. It does. That the patient is in a state where meaningful existence is not possible is irrelevant to whether the patient is deceased under US law, which turns on the person's physical condition, not on anyone's intention. And ambitious district attorney might convincingly argue that physicians following NRP also intended to render irreversible any brain functions that had not permanently ceased, thus ensuring the patient's death. In other words, an ambitious DA might bring up a doctor for murder. Now, NRP has been going on in this country now for about 4 years. Some centers do it, some don't. We don't here. Our ethics committee did not think it was ethically acceptable for the reasons that we've discussed. As far as I know, nobody has been brought up on charges for this. So this is an academic article which says, though, in principle, legally, that one might bring charges because you're basically killing the patient by ligating the vessels to the brain. Now, myself and Dr. Lydia Dugdale, who was a co-chair with me of the ethics committee, we were members of the ethics committee of the American College of Physicians. And when this was brought up to our ethics committee in 2020, because our cardiology department wanted to do this and wanted ethical imprimatur, we were troubled by this. And we presented this to our ethics committee, and the ethics committee was troubled by this as well. We therefore, Dr. Dugdale and I, brought this to the attention of the ethics committee of the American College of Physicians, which then came out and printed and voted on a statement of concern in April of 2021, which said, the assertion the donor has already been declared legally dead by another definition is unpersuasive. Because death has been declared doesn't mean the declaration can't be invalidated retroactively by subsequent acts. The ethical obligation to respect persons, including the dying and the dead, limit what can and should be done in organ retrieval. Remember, you have this picture of an individual lying there, chest open, brain, the face blue, heart beating. Is there something about violation of human dignity in carrying this out or not? Postmortems done on dead people are not particularly dignified, certainly, but nevertheless, this is a person who's sort of hovering in between life and death, or is the person alive, etc. How adequate, now here's another issue, how adequate is informed consent in DCD-NRP? If the patients or the family members are not made aware of the full details of what this protocol involves, the lack of transparency can damage trust in healthcare. When the organ procurement organization sits down with families and asks them for permission for DCD-NRP, do they tell them that there is a debate in the country as to whether this is ethical or not, as to whether we're killing people or not? I guarantee you the answer is no. You want to be an organ donor, that's wonderful. That's a wonderful altruistic thing. Is it ethical, though, for a family not to be told of the ethical questionability of this by people who think very deeply about this and who are very much involved in organ transplantation as well? How much do families want to know, and how much should they know? Again, the ACP statement of concern, further, what we called for in our ethics committee was mirrored by the American College of Physicians statement. Further professional and public discussion of DCD-NRP, a protocol more accurately described as organ retrieval after cardiopulmonary arrest and the induction of brain death. Further discussion is needed. I think that that's a fairly accurate description of what actually occurs. The American College of Physicians recommends the use of NRP-DCD be paused. The burden of proof regarding ethical and legal propriety of the practice has not been met. Now, you should know that we need hearts, right? We've said there's a shortage. There happens to be an alternative way of getting hearts with DCD, which do not raise these ethical concerns, which makes it even more ethically problematic of persisting with DCD-NRP. What is this alternative way of getting a heart? Again, it's called ex vivo procurement and perfusion. What happens? It's the usual DCD protocol. Ventilation is removed. Patient is not brain dead. After 5 minutes of absent perfusion, the patient is declared dead by circulatory criteria. The organism itself, ECMO, is not used. The heart is taken out of the chest, put in a box, and the heart is resuscitated, not the entire body. The heart resumes beating in a box. The patient is left, however, with cessation of circulation. There is no ligation of the vessels to the brain because the heart is not pumping blood in the body. So it's called an ex vivo procurement. And this really avoids the ethical issues of the violation of the dead donor rule. But there are people who say, well, these boxes cost $40,000. It's really quite expensive. When you're dealing with a procedure that involves about $1 million, it's a questionable question. But anyway, just put that out there. And also the question is, are hearts procured in this manner as good as the other hearts? So far, the data shows that the survival, at least at 1 year, is the same in people who get hearts with the ex vivo and people who get hearts with the NRP. There is a somewhat higher percentage of heart malfunction transiently after implantation of the heart following the ex vivo manner of retrieving the heart. However, these hearts generally with appropriate treatment come back, are beating fine, and the 1 year survival is comparable. So it again raises the ethical issue. Why indulge in an ethically questionable procedure when you have a viable alternative? Now, the arguments in favor of DCD-NRP donation, just to summarize, it doesn't violate the dead donor rule because normothermic regional perfusion doesn't restore natural circulation. Rather, the artificial in situ regional circulation perfusion of organs. The declaration of death by circulatory criteria, therefore, is not retroactively invalidated. I'm trying to give you both sides of the question here. NRP does not induce brain death because the patient is already dead by circulatory criteria, and circulatory death is premised on the permanent cessation of brain circulation. And since NRP is regional perfusion from the neck down, it maintains a permanent state of cessation of brain circulation. However, the maintenance of the permanent state of cessation of brain circulation is because we have ligated the arteries to the brain. But this is again using the approach of those who are pro DCD-NRP. They say there are clinical advantages to NRB. There is less delayed graft function, which I described to you now. However, 1-year survivals are comparable. Cost-effective technology. We don't have to pay for the $40,000 box that is used in ex vivo. And now here is a real problem. When it comes to pediatric hearts, babies, there is a significant shortage of baby hearts. There is no ex vivo possibility in the pediatric world. And therefore, the only manner in which hearts can be obtained for babies and very small children is either brain death in babies, which is not that common, or using DCD-NRP when there is not brain death, but the parents wish to remove the life support, in which case DCD-NRP is carried out. And so that is, in the pediatric world, the ethical issues are somewhat different because of the lack of an option. In June 2023, the American Society of Transplantation came out with a statement on DCD-NRP. And they said, the American Society of Transplantation, we support the use of this technique and the development of associated strategies that promote its clinical implementation. So we support it, but it then says, and I'm going to number 3, critical ethical analysis should continue to ensure adherence to the principles of the dead donor rule and preserve public trust and donation. So they're saying, let's continue doing it, but also let's continue to see if it's ethical or not. And some people might say, maybe we should figure out if it's ethical or not first, and then decide whether we should do it. But that's what the statement says. In terms of informed consent, number 2, studies pertaining to how much detail should be shared with families regarding organ recovery. We should do studies to see how much people really want to know. And we should do our informed consent based on best practices already established by organ donation agencies and standard DCD. And the last number 4, legal clarification, either through updates in the Uniform Determination of Death Act or other legal advisory or guidance should be developed to remove any perceived misalignment or legal barriers to NRP. So here again, they're saying, let's go on with it, but let's continue to look at the legal and ethical issues. Maybe it's not kosher, and maybe we'll decide not to do it. And so many people would say, you have it bass-ackwards. We should really be doing those things first, and then we'll decide whether or not to do it. Pardon my language. In summary, the current DCD-NRP protocol may violate the dead donor rule by resuscitating the patient and the donor, thereby retroactively rescinding the declaration of death by circulatory criteria, which requires permanent cessation of circulation without conditioning whether circulation is restored for the patient's benefit or not. Prior to restoring circulation with ECMO, physicians ligate vessels to the brain, lest resumed circulation to the brain will prevent brain death and possibly restore awareness. Ligation of cerebral vessels may be deemed as killing the patient by inducing brain death in a still living patient. I might add, by the way, that this procedure is not allowed in Australia and not allowed in Canada, which does allow euthanasia, by the way, in certain circumstances. That's a somewhat of a puzzling thing, but I bring it up because it's true. There is a national consensus on the ethical acceptability of regular DCD. There is not a national consensus on the ethical acceptability of DCD-NRP, and the fact that national medical and surgical societies, other than in the American College of Physicians, have not weighed in on the ethics of DCD-NRP raises red flags. Most national associations have shied away from this. They think it's too odd a thing. Let's just do it or not do it, but we don't want to come out with a stance. The ACP is the only large national organization that has taken a stance, and you saw it called for a holding on it until we ferret out some of these legal and ethical issues. What are the possible approaches to the problem then in getting more hearts? Continue to perfect the ex situ, ex vivo alternatives to in situ NRP. There is a large ethical difference between perfusing an individual organ versus perfusing a person. Let's try and achieve societal consensus to revise the circulatory definition of death. And I might add that there is pretty much a national consensus on DCD per se. And lastly, let's try to achieve societal consensus that the dead donor rule, whether or not it should be modified for purposes of increasing the quantity and quality of organ donation. And so fairly complicated. I hope I was able to get through the main points there, and it's a lot of food for thought. Thank you for your attention.
Okay, that was terrific. And for a complex set of issues, thank you so much for making it so accessible. So I want to encourage those who are online. I think we have about 100 people in the Zoom room to really submit your questions through the Q&A. I'm looking at the participant list. I know there's a lot of wisdom in that Zoom room. So please do submit your questions. But I think I'm going to take moderator's privilege and just ask you, Dr. Prager, if you could describe a little bit more about the decision at Columbia and whether or not there's a distinction between adult patients and pediatric patients, given what you've described in terms of the alternatives and what the process is with the ethics committee, just so for people to understand how policy is made. Absolutely. Well, first of all, as I said, this was first brought to the attention of our ethics committee in 2020. At the very beginning of this, and NYU was already, they had done about 5 or 6 cases of this, and members of our cardiac group wanted to see if we should start doing it, and they asked for ethical permission. And when it was presented to our committee, which is a multidisciplinary committee of about 25 people, not just doctors, nurses, patient services, social work, pastoral care, community representation, nurses, so a wide variety. The clear-cut consensus of the committee at that time was, this is ethically fraught. We need to have a national discussion on this. We are basically talking about when a person dies, whether we are violating the dead donor rule. It should not be up to individual hospitals to say, we think it's ethical, we don't think it's ethical. This should be a national discussion. And so we put this on hold. And I must give credit to the hospital, which had certain pressures to go ahead with this because we're in competition with NYU in terms of our organ transplant program. There are financial ramifications as well. However, the hospital, absent and the cardiology group, absent the approval of the ethics committee, did not go ahead with DCD-NRP, basically because our ethics committee did not give its approval. We re-examined, we've had multiple subsequent meetings about this as this has evolved nationally as well. We were recently put into a quandary when I got a call one day from the director of our heart transplant program, and this is another ethical issue for you to consider. There was a young man with Marfan syndrome who needed a particular syndrome, had heart failure. He was on the heart waiting list, and it was very difficult to find a match for him to get him a heart. And we could get him a heart, but it would only be a heart procured by DCD-NRP in another city. And the organ procurement organization said, the only way you're going to get this heart is if you let us do it DCD-NRP. Is that ethical? Can we say we're not going to do it, but we will accept the heart? And frankly, given the acuteness of the situation, which could have been a life and death sentence for this young man if we had said no, I basically had a discussion with the director and said, I can't see withholding a heart and possibly allowing this young man to die when the heart is taken legally. It's not against, we have no laws against it. And so this, and it was a decision that had to be made very quickly. Subsequently, our ethics committee now has looked at the issue. Shall we take hearts elsewhere while not doing DCD-NRP, or is that hypocritical? And as of today, we feel that we do not feel that our patients should be disadvantaged, punished in a way by not allowing hearts taken elsewhere with DCD-NRP, and thereby possibly condemn them to death for want of a heart, but not doing it ourselves. So we're in this kind of limbo situation right now.
And it does raise obviously ethical issues.
Yeah, so can we talk a little bit about that decision actually, and,
Yeah.
and the kind of ethical calculus that's involved in receiving, so
Yep.
accepting organs that have been recovered through NRP with the use of NRP, but not doing it at our institution.
Right.
And to what extent are we kind of shifting the balance in terms of benefit to
Yep.
patients, harm potentially to donors? Just thinking about the
Yep.
ethics and not the legality.
Well, first of all, I want to stress the fact that we do DCD ex vivo here, a DCD with using the ex vivo, and we will even have our surgeons fly out to another city to retrieve a heart via DCD, but without ECMO, without NRP, using the ex vivo machine. So that, I just want to put that down there. So we do employ DCD, but not NRP. Look, many ethical questions and conundrums are conundrums because there are compelling arguments on both sides. And it's not black and white. And given the fact that we may be talking about a life and death sentence for somebody, to say to somebody on our group, we are not going to accept this heart, you may die for want of a heart, because we feel that it's wrong to do it, even though there are ethical people doing this elsewhere and it is not illegal, we feel that that's wrong. We feel that the consequences, potential life and death consequences to a patient of ours by not accepting a heart that way, when that might be the only heart available for them, is not acceptable. So we're put in this difficult position, and I'm sure there are arguments against that. We're being inconsistent and so forth, but we are dealing with the life of somebody, and we are dealing with a procedure that is considered, that is not illegal in the country and is being carried out elsewhere.
Any follow-up on this particular question? And we'll take those first. And a microphone's coming to you.
Thank you, Ken. Brilliant as usual for the simplicity of your explanation of a very complicated topic. If you could scroll back to slide 12 while I ask my question. If what we're wrestling with is the fact of the unavailability of a further intervention after the patient has been declared brain dead, keep going back, 2 more.
I'm going forward here. Should I be going back?
Yeah. Some of your slides weren't numbered. There we go.
Okay.
If as a ethical matter, we substituted the word permission for intention in the 3rd line, because there is no permission to resuscitate the patient, would the notion that the patient is permanently dead because permission to resuscitate is absent, has been withheld by the agency of the patient, would that make you view DCD by NRP as more ethically permissible?
To me, it would not, because permission is one thing, physiology is another. We are actually resuscitating the patient physiologically, even though we don't have permission to do so. So although the family says we don't want our loved one to be resuscitated, I think physiologically we are. I mean, so I draw a distinction between permission and physiology. And I think it's, you know, the procedure that we use, by the way, in DCD NRP with ECMO is precisely the same procedure that we use to try and resuscitate somebody who's had a cardiac arrest that we want to live. It's the same thing. We do the same thing, except that in the case of somebody who has arrests on the street and we take them and we do CPR, it doesn't work, and we then hook them up to ECMO, we try to bring them back to life, but we don't ligate the vessels to their brain because we want them to live. So it's the same exact procedure minus the occlusion of the carotid. So to me, it's the same, and it's cardiac arrest with the induction of brain death. That at least is my take on it.
But the cross-clamping is done with the patient's permission and in fact request.
Yes, but we also don't, but physician-assisted suicide is not legal in New York State.
Not yet.
Not yet. And I have problems with that too, but that's another lecture.
Okay, I think we have a follow-up back.
Yeah, thank you so much. And I think that clarifies my question as well, which was whether I was wondering if you felt that a solution to this is to alter the uniform definition of death, but it sounds like you don't feel like that because physiologically,
Yep.
we're not getting around that by changing the legal definition.
Yep.
And then what if we didn't ligate?
What if what?
We didn't ligate.
If we did not ligate, there is every possibility that there would be some degree of sensation in a patient who is not brain dead, and we're opening
Right,
them
we're
up
not gonna,
and
then
experiencing
it
pain.
would then.
Absolutely.
Anesthesia would be introducing other.
Yes, yes. And in terms, by the way, of the dead, modifying the dead donor rule, there is a call by certain centers in the country to modify it. I personally think it would be a public relations disaster for the public to say there are circumstances where it's okay to kill somebody for their organs. As you can see, if one takeaway you can take away from my talk is that this is very complicated. It is very nuanced. And for the average person thinking of this in a holistic way, I don't want to be killed for my organs when I go into the hospital. I want to give my organs. I want to make sure that I'm dead. And when you get into the nuances of ligating brain, yes, brain death, permanent, this and that, people are going to fog out. They just want to be sure that they're 100% dead. They're not going to feel anything. And so even to put that out there, that we're modifying the Uniform Declaration of Death Act, the dead donor rule, I think will cause more harm than good.
Okay, I'm gonna take a question from the Zoom room. So Mark Richmond asks, when NRP is used for only abdominal organ procurement,
Yes.
why are there not the same concerns as with the thoracic abdominal?
That's
NRP?
a great question, and that is somewhat of a nuanced answer. When we do a normothermic regional perfusion, DCD, when we just get the abdominal organs, what happens then is that a balloon is put into the aorta above the kidneys. And so what is resuscitated are just the liver, kidneys, pancreas. The heart is not resuscitated. Circulation is not restored autonomously. And so in that case, I think a more convincing case can be made of resuscitating, reperfusing organs in situ. The heart is not resuscitated in that case, and therefore I think people feel a lot more ethically okay. We're not resuscitating the organs as a whole. And so that would be my answer. It's really the restoration of endogenous circulation with the heart pumping. That's what really causes the ethical problem of we're really doing resuscitation, but we're occluding the organs to the vessels to the brain to prevent any sensation and brain resuscitation.
Okay, I'm going to take one more question because they really are coming in, and this is one I think it's important because you emphasize the problem of informed consent and fulfilling the principle of respect, particularly for families. And Conrad Erb asks, can you offer an explanation for a layperson on why a perfect consent process by the donor does not resolve the ethical concerns here? I can imagine that a typical patient might say that there's no ethical consideration. If they can simply consent to NRP, I can see many patients consenting fully to NRP, and especially if the recipient is family member, close friend.
Yes, so it's an excellent question. I would say that even though we would have perfect consent and the person would understand exactly what's going on, we place limits on patient autonomy in this country. Patients may have perfect consent and say, Dr. Prager, I have terminal cancer. I want you to administer to me a lethal dose of medications. We say no. We don't give people absolute consent. And so if we feel that we are killing the patient in DCD NRP, even with perfect consent, and somebody says, I understand this, it's perfectly fine, but the good that will come from this is greater than the downside, I, as a physician, may say, I will not do this because I think I'm taking the life of the patient. So I think there are limits on autonomy of patients and of families as well.
Thank you so much. This is such a fascinating and clearly very fraught and difficult topic. I'm just wondering if there's consideration that by accepting NRP organs, there's essentially a pipeline that creates conditions in which the most urgent or the most problematic cases where someone is in need of an organ, actually the greatest burden is then with the most unethical choice. That it actually creates an ethical quandary where very fraught situations, right, almost make it that the only available option would be the most unethical in your perspective, right? Because we don't perform an RP.
Right.
So just to raise, they're actually creating a system where there's not a way to move away from a choice that is so ethically tenuous.
Yeah, although the case that I presented to you was the case of a very difficult to match patient, I don't think in general that that is the case. So I hear what you're saying, and what you're saying is that we may end up pairing the most desperate patients with the need to do DCD-NRP. I don't think it would work that way. I should also say, by the way, that I think we've had only one instance where this has happened. So this is not a common, it's not a common occurrence. And I think it's a theoretical concern, but I think practically speaking, it's not an issue. The greater concern is just finding a donor out there, doing it either from a brain dead patient or DCD ex vivo. That's the way it happens almost always.
Okay, we'll have one last question here in the audience. Right.
Thank you so much for your talk. I had a quick question about sort of pre-hospital settings. So I guess in like settings where patients need to be transported, we need to make decisions about like what medical centers would patients need to go to. I guess when there are considerations like, you know, what centers are best able to like amputate or provide care that's best for the patient. Do you think there's a future in which like NRP is considered as a factor and maybe patients might be prioritized and delivered to centers that are able to do this kind of?
Well, I don't think it would be where patients are delivered, but I think that word might get out that if you go to NYU, you may have a better chance of getting a heart because they do DCD-NRP, whereas at Columbia, they don't. I think that is something. And in fact, that was raised in the ethics committee as, should we be saying to all of our patients on the heart waiting list, we do not do DCD-NRP here, and you might have a slightly better chance of getting a heart in a facility which does do it. I don't know, by the way, that really comes, again, because of the ex vivo option, which is being used by a large number of centers. I don't think it's come down to that your chances are 100% better and so forth. There may be a slight advantage in certain circumstances, but you do raise a good point. And we'll see what happens really with time. With more and more, what I really think is going to happen, frankly, I think that this is just, I think the horse is out of the barn. I don't see going back, frankly. I think the American Society of Transplantation's notion, let's think about the ethics, but let's keep doing it. I personally don't subscribe to that, but that's what's happening. And eventually, we may even end up doing it here at Columbia because by everybody doing it, maybe we'll say there is a national consensus. So we'll see, but this is a work in progress.
All right, please join me in thanking Dr. Prager for a wonderful presentation. All right, I do, before we close, and I'm gonna get to the slide, want to let you know about our next ethics grand rounds that is scheduled for November 12th at 12 p.m. also in this room, and it will be with Dr. Merlin Chungwayan from the Mailman School, and he will be discussing his new book, All Health Politics is Local, Community Battles for Medical Care and Environmental Health. You can see here the QR code if you'd like to register either in person or Zoom attendance. And then finally, I just wanted to make sure that you please fill out the post-event survey. We take your comments very seriously in terms of how we organize the series. So please do send your comments and suggestions. And with that, I will bid you all a good afternoon. Thanks so much. It was great seeing you all.
Thank you.